Good afternoon. Good afternoon. I'm Jill Holt with Mountain Pacific, and I'm letting everybody kind of get into the presentation and get situated here, and we'll start in another 30 seconds or so. All right, well, once again, welcome to It's Worth a Shot. This is session number 14. It's a two-part series. We have a webinar section on just a general webinar for information, and then we also have a clinical office hour section during this presentation. So we're going to begin. Mary, if you would advance to the next slide. I want to begin with just some housekeeping items. Just a reminder that we are certainly open to any webinar topics or clinician ideas that you might need in your facility. We're happy to put something together. So please, you can put it in chat. You could email any of your account managers, Marcy Gallagher, Dana Mitchell, Jesse Kinsey, or myself, should you have ideas or questions that you would find helpful in this kind of a platform. So just keep Mountain Pacific in mind for those needs. We're happy to help, and we're free. So there's no charge for our services. All right, next slide, please. I wanted to just spend a second going over a question that came up last week regarding masking guidance for long-term care. This is not hospital-based guidance. This is for nursing home. And I did respond to the question, but I thought I may have omitted what could be an important part of the formula when making a decision. So let me just run through this quickly, and then we'll get rolling with our presentation for this week. So the question was, what is the guidance for long-term care? And that there have been changes most recently regarding source control, and source control is still recommended, but there can be some exceptions for those staff members who are up to date with all of their COVID-19 vaccine doses while working in a healthcare facility in a county with low to moderate community transmission. And some of the other criteria or considerations that you want to make sure that your staff is aware of is that if a staff member who is up to date wants to take their source control off or remove their mask, they may choose to do that in an area where there is opportunity for social distancing and not in a resident or patient access area. So I just felt like that needed a little extra commenting. I wanted to make sure everybody had that information. And we do have some CDC guidance links that we can provide, and I can try to get that into the chat this afternoon. We can send it out with next week's reminder too. So just wanted to make sure that we tightened that piece up. So any questions about that or comments before we move into today's presentation? All right, well, we're going to start our presentation today. You can advance to the next slide. Thank you. The first part of our series today is regarding the admission process for pre-screening, financial, and clinical reviews. And it's my pleasure to introduce Stacy Holt. Stacy is the Regional Admissions and Marketing Director for Peaks Healthcare Consultants. And so I'd like to turn it over to you, Stacy.
Hi, thank you for having me. So a little bit about Peaks. We are relatively new. We do own buildings throughout Wyoming right now, from Casper, Cheyenne, Sheridan, and Cody soon. So like I said, we're a pretty new company, and Peaks isn't well known. So I was the Admissions and Marketing Director for Casper Mountain Rehabilitation and Care Center in Casper, Wyoming for 2.5 years. So yeah, we can go, we're going to discuss the admission process. Sorry, my mom's calling me. Let me mute her. So anyway, I threw this together for Mountain Pacific for this, and we're going to discuss some pre-screening financials and clinical reviews that our company just has a foundation for all three of all of our buildings to build off of. So we're going to discuss financial, clinical, acceptance, and communication. So next slide, please. All right, so referral sources. Obviously, the hospital and some of the rehabilitation centers are our biggest referral sources. Long-term acute care hospitals from surrounding areas, we get a lot from Billings. I get referrals from Rapid City, Denver area, around our surrounding areas, home health agencies, primary care providers, and I guess families and word of mouth. So those are our referral sources there. Next. Financials. So with our company, we really want to structure around the resident coming in to know that the only thing they need to focus on is their well-being, rehabilitation, if that's what it is. We want them to be strong and healthy and be able to go home and focus on that only. So when we do receive referral, what we look at is who are their payer sources? Do they have Medicare? Do they have Medicare? And then do they have a secondary payer source? Is the referral held an HMO or a PPO as a primary provider or payer? With that being said, there are differences because many of you maybe know this, I don't know, please step in if you do, but Medicare has 100 days that they will pay for. The first 20 days in a skilled nursing facility are paid at 100% as long as there's a skillable service. So this is one thing that I do stress to my families if I know they don't have a secondary payer, because they, in the long run, they may have a financial a statement that we have to give them and have that worry. So we don't want to do that. We want to make sure that this is all said and done prior to them setting foot into our door. Days 21 through 100 of the 100 days of Medicare only pays 80%, and then the patient or resident is responsible for 20%. So right now, Medicare is up, I think their co-insurance is at $185.50 a day. That adds up pretty quickly if you don't have that secondary payer. So those are things that we make sure the family and the resident knows ahead of time, along with working with the case managers. The HMOs, a lot of those policies will only cover so many days in that 100 days. So for example, the first 20 days may be covered at 100%. And when I'm talking about an HMO or a PPO as a primary payer, this means that it's a Medicare plan, but not traditional Medicare. Which kind of throws a wrench in the whole financial system. And a lot of people don't understand what their plans are until they're in this situation, unfortunately. So they may have, back to the 20 days, they may have the first 20 days paid at 100%, but day 21 through 52 or 55, those may be those co-insurance days at $185 a day. So what we do in return is we give this information to the families and case managers, and we do ask them to pay for a portion of this up front. All of this is refundable. So lots of time with the families and the residents on the phone. You know, that's, like I said, my goal is to make sure they don't have this burden when they step foot into any of our facilities. Right now, Wyoming has PASSAR and LT 101s. They're kind of psychosocial evaluations for those diagnoses of if they have some psychiatric issues going on. LT 101 is basically how we get paid for Medicaid. We're any payer source at this point in time. So this, as of May 1st, is a requirement for pre-admission into the buildings. So if we don't have these done prior to admission, there is that risk that we won't get paid through Medicare or their financial institutions. So one of the other things that plays a big factor in financials are medication cost review. So one of my job duties when I was in that role was I was looking over all of the medications. IV antibiotics, for example, can be very expensive. And so, you know, we have a limit as to where, okay, so if there's this antibiotic that costs $2,000 per, let's say they get it 3 times a day, so it's gonna be $2,000 a day, let's say. You know, we wanna make sure that A, the insurance company is gonna pay for it, and B, do we wanna take that on as a financial risk? So, you know, there's a lot of medications that play a factor in our decision in financially accepting a referral. there any questions on that so far? No? Okay, next slide. So next step is a clinical review. So we do this methodically. We want to make sure that the resident is going to be a good fit for us, but we're also going to be a good fit for the resident and their family. So what you look at are behaviors, medications, wound care, what stages of wound care, infection control. Are they going to have to be isolated? MRSA, COVID, all those that come into play in the factor too. TPN, we don't admit anybody with TPN. They have to be off of that. And then medication costs again, and then also vaccination requirements. So with our facility and our policy is that we do require them, all residents admitting to our buildings, to have be vaccinated if you can, when require all the documents for that. But we also go above and beyond, and we go into the Wyoming immunization record, and we pull those records too. And that helps with the case management also. If they have not been vaccinated, then they are required to isolate for 14 days. And then they can come out of their rooms, but they'll still maintain and get all the therapies and the skillable services that they require. Before, we also ask that the hospitals or wherever the patient is coming from, that they obtain a COVID test prior to admission, at least 72 hours. And then we'll test them again when 3 days after they admit. So we are still testing our employees on a weekly basis. We're also the masking, screening at the door for all visitors. Our facilities are wide open, so we still following following the CDC guidelines, but we're also still going a little bit above and beyond to keep our folks safe. Staffing issues may become an issue. We've all heard this, I don't know how many times a day. Our staffing right now in Casper is pretty good, but our other facilities are seeing that struggle. So admitting a resident, that kind of falls in that medical complexity. Are we going to have the staffing to be able to maintain if they have IV antibiotics? Do they have, how many wound care, how many ulcers do they have that we need to take care of? So we really look at that also. I put family on here because I have had struggles with families that are very, how do I say, VIP. So if we've worked with them in the past and we know they've given us a hard time, stuff like that, we really want to be careful with that in our staffing also. It's everything is a case by case. So we never want to rule anybody out, but sometimes family does play a role within accepting residents. Any questions about the clinical review? We usually do this within a 15-20 minute time frame. So we are pretty quick getting back to the case managers for admission or accepting for a referral. All right, next slide. Winning the referral. So once I know that we have been accepted, or the resident has chose to come to Casper Mountain Rehab or any of our other facilities, I speak with the family right away. Like I said, the financial is, I would want to know where we're at with the financials before I move forward with making a decision. So one thing that we do go above and beyond is that if we know that there's not a secondary payer for said resident, that we will start the Medicaid application process with them, and we will follow them through. Even if they don't choose to come to our facility, that's one service that sets us apart from some of our competitors. So communication is key with all referrals. At any stage of that referral, you're always trying to win the case manager, you're trying to win the families and the resident too. So that's pretty important to keep that communication line open. Next. All right, relationship building. That's all about admissions. Communication is key. Speaking with those case managers on an hourly basis after you even receive the referral. I am in constant communication with them, just letting them know where we're at with the process. They're letting me know where the family is at the process. And usually I become that go-to between the hospital and the families, because the families will end up getting more information out of me than they do some of the case managers. So I become that go-between. And it works out pretty well. Be present and forthcoming, be able to make sure you're present. You're up at the hospital, introducing yourself to the residents, their families, making yourself available. Transparency with families, going back to that financial, I'm straightforward with them and letting them know that, hey, this is what's going to be, this bill is going to be due. We need at least part of this. We can work with you, but we need at least part up front, and knowing that, just reiterating that it is all refundable if the resident doesn't go past so many days. So I'm hoping this makes sense, because to me, it's just like an everyday conversation I'm having. So if you all have any questions about this, please speak up. I will not be offended at all. So educating the families with the Medicaid application, or what our process is. What is it going to look like on day one when you admit to our facility? You're going to be with the nurse, your nurse, for about an hour, hour and a half, for them to do their skin, head to toe skin exam assessment. And then if you're there early enough, then the therapy team tries to get in on the same day and start working with you right away. After that, I educate them as we do care conferences within 72 hours of admission, and explain to them what that means, well, who's involved, and we start that, and what the discharge plan looks like too. Give them all the information regarding their insurance information, what they will and will not pay for, when we're going to be admitting the family member. So it's constantly educating families about the routine and what to expect. Up-to-date information with the facility. What things that I've done, and I've actually passed on to some of our other admissions director, is making sure that you can send out emails or call the hospital case manager director, just keeping them in the loop of what's going on in your building, such as, right now at Casper Mountain. The only reason I know this because I was just there. We have no COVID in our building and have not had COVID. We are still testing non-vaccinated folks once a week. Our staff is being tested once a week still. We're still screening, and we have 5 rehab beds available at this point in time and 3 long-term beds available. So letting them know that what's going on in our building, how many beds we have available, goes a long way. And I not only do that to our locals, but our surrounding communities, I keep in touch with the case managers that way too, and let them know what's going on as well. Show appreciation toward referral sources. So I try to get by with lunch and learns, but those are slowly decreasing as bigger companies are taking over our little hospitals. So I just, like I said, I try to do lunch and learns as much as I can, have lots of education to give to the case managers. For example, tomorrow we're having a lunch and learn, basically, with the other facilities around town and our CMS star ratings. So we're all getting together and kind of having a powwow about that. And the other thing is just go that extra mile. I'm a go-getter, and I want to know what's going on. Why aren't we getting these referrals? And that's worked for me. I get a lot of positive feedback. I get a lot of negative feedback too, but just, knowing that you're there and they can rely on you, the case managers, families, that kind of stuff. So it carries you a long way. I think that's it, if I remember. Yeah.
Thank you, Stacy. That was great. That was very comprehensive. That's a lot in 15 minutes. I know, a mouthful.
Mm-hmm.
We appreciate you sharing your process with all of us. And I know it's really important to understand vaccination status. And I appreciate that you mentioned the resources that you use and how you address that, and informing residents, potential residents, of their quarantining status should they not be up to date with their vaccinations. So thank you so much.
Yes, you're welcome. Thank you.
We're going to switch gears now, and our next section we're talking about this afternoon are the ICARs, the Infection Control Assessment and Response. We had a little bit of a switcheroo today. Our guest speaker wasn't able to join us, so our Dana Mitchell on our Mountain Pacific team will be presenting this afternoon. But before we turn it over to Dana, I want to introduce Liz Adams. Liz works in Montana. She's going to share a little bit about her background, and she's on hand to be a backup should there be questions on ICARs, because this is what she does in Montana. So I'm going to let you, Liz, if you wouldn't mind introducing yourself to our group, please. And you're on mute, I think.
There we go. Technology, all these things that you have to get ready. So thanks for inviting me today. Yeah, I do work in Montana. I'm based out of Helena, and I'm an infection control specialist, and I work with the HAI program here under DPHHS. And we provide ICARs on site, and we also do outbreak consults. And so I've been doing that for just a little bit over a year now. Prior to that, I was working for about 9 years with the Certification Bureau doing the surveys for healthcare. So I'm glad to be here today and be of some help with the presentation today.
Thank you, Liz. And at the last minute, no less. So thank you so much. And then speaking of last minute, Dana got volunteered to help with this presentation. So Dana, I'm going to turn it over to you.
Yeah, thank you, Liz. You're even more last minute than I was. This is my second one I've stepped into today, so I'm getting into the habit. So thank you. I'm a nurse, but I am a quality specialist, not an IP. So I'm really thankful to have Liz with us. We had tapped Kelly O'Leary, who works for the Department of Public Health, HAI department in Hawaii, as well as functions as an IP consultant for the state of Alaska, to put these slides together. And I'm sad she couldn't make it, but I'm happy to step in for her. So next slide, please, Mary. We'll try to breeze through these as fast as we can. So I know a lot of you have ICAR experience, and all the feedback I get is that you've learned some great things from it. But I'm going to still go over here what to expect from them and how they're going to be, how they would be able to help you out. So an ICAR, you know, as the name implies, is an assessment and response tool. So they're designed to assess your strengths. They're free from your state, or offered by the state at no cost. You'll have an IP consultant that'll come in and conduct it, and they're using CDC tools and are really focused on educating and offering you the most up-to-date IP resources, which as we've been through the last 3 years, know that it can be critical. And they're going to be in your facility for at least a couple of hours. Next slide. So here's what you're going to get out of it. It's consultative. It is not regulatory. I know that's a big deal. We want folks that are going to come in and be objective. You'll get tailored resources, tools, and training to the specific areas that they discover while they're doing your assessment that are areas for opportunities. You'll get ongoing consultation with an IP, which I think, we've all really gotten to know our IPs really well over the last couple of years, and know how critical that can be. And great partnership for quality improvement. And then, of course, the center of it all is improving the health and safety of our residents and staff. Next slide. So they'll be setting specific, and they cover all these domains in the assessment and response tool. Everything from your program and your infrastructure to your EVS to PPE and hand hygiene, antibiotic stewardship. They'll cover all of that. Next slide. So we'll review quickly these domains. So the first is your infection control program and infrastructure. You've got to make sure you've got your person identified who's going to coordinate your policies and that they are trained in infection prevention. Then you're under the healthcare personnel and patient safety domain. That is where they'll take a look at your education. That's where they're going to take a look at your TB assessments, your vaccinations, your exposure control plan, respiratory protection plan, and your water management plan. We got bit by the water management plan by total surprise when they first decided that we needed to have that. And so it kind of became a running joke in my facility that they'll come around and sting you and you don't even know it. Next slide. Then surveillance and disease reporting. How do you identify? Do you have a process identified for your surveillance and reporting? What's in your written surveillance plan? Important in all of these domains is how you audit or monitor. What is your infection control risk assessment? They'll take a look at that. And how are you going to respond to outbreaks? I think we've strengthened those processes quite a bit, at least for respiratory outbreaks. And then hand hygiene. I haven't used, but I've looked at iScrub and this speedyaudit.com, and those can be really great tools to do random audits and be able to collate your data. Next slide. PPE. Make sure that your policies are all shored up for PPE, standard and transmission-based precautions. What's your training and competency validation? Again, are you doing audits and do you have supplies? Respiratory hygiene and cough etiquette. They're going to take a look at your processes for all of that, including do you have signs posted when it's necessary? What are your resources? And again, what's your education? Next slide. Antibiotic stewardship. She's got a link to the CDC core elements for antibiotic stewardship. I don't, maybe Liz can inform me on what the local health department meetings are for. I don't know if they will recommend maybe that you attend those for antibiotic stewardship, I guess I'm not familiar with what that element is. And then the injection safety and point of care testing. Again, policies, training, audits, and supplies. Next slide. And then they'll look at your EBS domain. Policies again, routine and terminal cleaning. What do you do with your shared equipment? On a call I was on this morning, they said our Department of Health folks were on, and nursing homes as well, saying that there's a sense that that there's a focus in on those vaccine surveys, that they're really looking at the movement of equipment and how those are being terminally cleaned, and that folks know their dwell time and what the processes are. If it needs to remain wet, for example, the purple tops need to remain wet for the whole 2 minutes, I believe it is. So do folks know that, and are they following those policies? Next slide. Next slide, please, Mary. Whew, wow. Okay, I guess that's the end of those slides. Liz, what would you have to add to that? And I know I saw Jill had posted a question about how frequently should ICARs be done. And I don't know if you have a comment on your local health department meetings.
Oh, okay. Now I think I'm unmuted.
Wait, rattle all those things off.
No, that's okay. Boy, and you got through that really quick. So I did notice that in the chat. And so we recommend every 6 months to a year. It kind of depends on how well you do on the assessment. If you have a lot of areas that maybe we can come back and help you with some training or things like that. So it really is individualized. And I will say that the acute tool, like hospital, that tool is a little bit more in depth as far as, your HAIs, and CLAPSI and CODI and all of that. And so those are a little bit more in depth, but yeah, I think probably the biggest thing, like you mentioned, is environment. And we want to make sure that, high touch surfaces, that there's checklists, that there are specific people being held responsible for those tasks, and that everybody knows what cleaning products, no one's bringing in their own cleaning products or sanitizer or soaps. We see that a lot. Also with environment, storage of materials, because you want to make sure that nothing's on the floor, that if a room is designated for something, that that's what it's actually being used for, and it's not having other things stored in it, like patient equipment in a med room.
Yeah.
So there's lots and lots of different things that we look at, and observations. We go through the entire facility and do observations of all the areas. And so that's why it's so important for us to be able to go on site to do those. And so I hope that kind of helps. And did I answer what you were asking, Dana? Did I get all of that?
I believe so. Does anybody have any other questions or clarifications that Liz or I could offer?
What about the local health department, Liz? I know that Dana was asking about your work with them.
Yeah, and so local health department is paramount for us because we help all of the counties in our state. We help our local public health. And so, we keep track of outbreaks, help them with that. But they're the bottom line as far as closing an outbreak. And then also they're the person that facilities have to contact and be in communication with regularly, not only for antibiotic stewardship, but for communicable disease, for immunization questions or help. I mean, your public health person is super important and for facilities. And so they should be your go-to. We're a help meet with that, along with now we have some congregate help meets for public health. And so, yeah, public health is super important to infection control for our counties and for us as a team too.
Thanks, Liz. Hey, are
Yeah.
you guys seeing any, are there any common concerns that you're finding on the ICARs that you're performing? Have you seen any patterns recently?
Actually, we do a gap assessment. And so we are in the process of scoring that for our ICARs. I think, like we said, environment is a big one.
Mm-hmm.
And then also, we also see staff training as far as injection safety that's lacking, especially not so much upon hire, but annually.
Oh.
And yeah, and so we are compiling that information. I don't know exactly when or how we'll share that yet. Because, of course, we have to have enough to be able to do that. But those are some areas. And then also with screening and entrances and making sure that you know who's coming in your building, that they understand what your expectations are to keep everybody safe when they come into your building. And that includes staff and visitors and volunteers and contract people. Yeah, and so I think those are some of the main things that we're kind of noticing that you want to keep your facility safe and secure with.
I think on the call I was on this morning, they mentioned, and this I think was specific to Alaska, but I think what happens in one state tends to trickle out to the others or be happening in the others is that the surveyors are looking at how your testing stations for COVID specific, how your testing stations are set up. And so they're seeing some citations on, are you keeping everything dirty away from everything that's clean? And what are your processes for maintaining the cleanliness and the order there?
Yeah, and then also, especially for long-term care, because remember, if you have a person that's entering your building, it can put you in outbreak. And so you want to make sure that that process is happening before people get into your building.
Right. Well, we have gone over by a few minutes. It feels like that just flew by. I think my last comment would be that to just reinforce that this is their consultative service and are not regulatory and are an incredibly good resource for you to get a handle on a deeper kind of look and a new set of eyes that's not going to cite you to help you develop your response plan and your infection control plan. So definitely take advantage of them.
Yeah, and I think CMS too, I mean, they really look at, well, of course, infection control, environment are focuses right now. And they really look at resident and patient safety. So if all of your processes, just make sure that you've got resident and patient safety addressed.
Yeah. So thank you so much for jumping on last minute with me. And thanks everybody for attending. And if, if this brings up questions or things you want us to go maybe further in depth with, just shoot your account manager, your Mountain Pacific contact person a message and we'll make sure we get it on. So thank you. Hope everybody has a wonderful afternoon.
Thank you, Dana. Thank you, Stacy and Liz.